So thank Myeloma UK for asking me to talk about treatment strategies in AL amyloidosis. Some of you I know, and some of you are new faces, but please feel free to stop, interrupt, or ask questions at the end as you feel appropriate. We hope that this talk will cover how we measure treatment response, what happens after treatment, how do we work out that the treatment has actually been successful, what is detected. You heard some of this in Julian's talk before. And then we'll try and go through some of the options that we have available for treating patients with AL amyloidosis, particularly when the disease might become active after the first treatment has been completed. So initial treatment, remission period, if the disease relapses, what can we do? And I hope we'll leave with three take-home messages. One is the fact that we can't really cure it at the moment. We might do in the future, but it can return after initial treatment. We can go through the tests and the symptoms that might help to identify when the disease is creeping back. And then finally, the treatment options that we have when the disease itself relapses. So what is really the aim of treatment of amyloidosis? What are we trying to achieve here? So we're trying to control the organ damage. My pointer doesn't work, but so we're trying to control the damage that the light chains have caused to the amyloid organs. We are trying to maintain the quality of life. And more importantly, at the end of treatment, we want to reduce the symptoms and actually improve the quality of life. That leads us to the discussion when somebody presents to us for the first time, what is the initial treatment choice? This may be chemotherapy of one form or the other to kill the plasma cells in the bone marrow, or occasionally, in maybe 10% of our patients, we could consider a high-dose melphalan and an autologous stem cell transplant as a first-line treatment option. Once we've been diagnosed, you will have regular tests, and you might have heard of serum-free light chain testing. All of you who have been to the Amyloid Center would have left with a whole package of bottles that you send back to us every month for measuring serum-free light chains. As Julian said to you earlier, light chains are the disease driver in amyloidosis, and measuring light chains gives us an idea about the activity of the disease. The light chains come off this intact protein, which is made by the plasma cells in the bone marrow called the paraprotein, and we also measure the paraprotein. So using the paraprotein in the light chains tells us about disease activity. Every time you come to the amyloidosis center, we'll do imaging. You have an echocardiogram, sometimes a cardiac MRI scan, which you may hear about a bit later, and the SAP scan, we'll talk about that in a minute or two. We'll do various tests of organ function, blood counts, liver function tests, kidney function tests, albumin, to assess whether the organs are getting better, remaining stable, or improving. When you start treatment, the first sign of a response is reduction in the serum-free light chains. The chemotherapy treatment or the stem cell transplant will kill the abnormal bone marrow cells, and as the cells get killed, the light chains will progressively come down. This leads us into definition of the terms which you might hear talking when you come to see us in clinic. The first thing we talk about is a hematologic response. You have had a good response, you have had a moderate response, you have had not so good a response. The hematological response is the percentage or the proportional reduction in the light chains compared to the starting value. That is the absolute key. As Julian said earlier, it is really crucial that how sticky those light chains are determines how much amyloid you have, how quickly it will progress. But also, we know that the proportional reduction in light chains is absolutely crucial to allowing the body to catch up, break down the amyloid, and the organ function to improve. The second term you will hear is you have had an organ response. In this time, we're talking about what has happened to your affected organ. Is the heart working any better? Are the kidneys leaking less protein? Is the liver function improving? We then talk about amyloid load, which is what we can detect on the scan. Has the amyloid burden in the internal organs, the liver, the spleen, the kidneys, improved on the SAP scan, which we will be seeing in a minute. This is the scan all of you had when you came to the Amyloid Center for the first time, and then you'll have it every visit mostly. SAP scan was invented by Professor Hawkins and essentially involves a protein called SAP. All amyloid protein made by light chains have other proteins which are stuck on top of the amyloid fibrils. SAP is one such protein. What we do is label the SAP with a radioactive tracer, give that as an injection. When the radioactive labeled SAP goes in the blood, it will circulate around and then go and stick to the amyloid fibril deposits at different parts of the body. You then go on to the SAP's a gamma camera for the SAP scan, which is usually 6 to 24 hours later, and then we get these pictures. This is a patient where you can see a black liver and a spleen. This is lots of amyloid in liver and spleen. We'd call this as a moderate or a large amyloid load. This is the same patient about 18 months later who had a good response to treatment, and you can see that the amyloid load in the liver is markedly better. The liver is not as black as it was. This is the spleen, which works as a filter for the blood. That's better as well. So this is what we'll call as regression response improvement. This is very variable. This patient had a fairly rapid regression of amyloid. Sometimes we see it slower, sometimes we don't see it at all. Once the treatment has been completed, you will come across these different terms of response. You will talk about remission. We might have a term called very good partial response, or VGPR. You might hear about that, a complete response or a partial response. A complete response is the easiest to understand. The light chains have gone back to normal. The paraprotein from the blood has entirely disappeared. A very good partial response is the light chains have reduced down to maybe 90–95% of their starting value. That's mostly good enough to stop the amyloid from building up, and also generally good enough to allow the body to break down the amyloid protein. Partial response is a 50% reduction in the light chains from their starting value. A few years ago, we would think that a partial response was good enough, and in some patients it indeed is good enough to allow the body to break down the amyloid protein. But these days, we are generally feeling that most patients need to be in one of these two categories, and we sometimes prolong the treatment till one of these boxes is ticked. Stable disease is where the light chains don't change at all. We don't like that very much, and we change treatment quite quickly. No response, obviously, means that the light chains have not gone down at all. They sometimes creep up in treatment. That's very unusual these days. And then there's this term called plateau phase. We used to use it quite a lot. In multiple myeloma, we were using it in amyloid. It essentially means that the light chain or the paraprotein level came down, and then it has stayed down for some years. That's the plateau phase. It becomes flat. We measure it the same number. Paraprotein of 5, light chains of 50, or whatever. That's the plateau phase. We don't use this term anymore, as we have started using these terms much more often. And all of these will then lead to improvement in symptom from amyloidosis. So here we are. This is how it might look. There are light chains in the blood. They've been circulating sometimes for many months, sometimes for a few months, sometimes for many years. This is when the patients will present with symptoms. Diagnosis is made. We decide a treatment plan. When the treatment starts, the light chain levels will come down. Now, this is very variable. In some patients, the responses are rapid. The light chains might come down in 1 month, sometimes 2 months, sometimes 5 months. The goal at the end of treatment is that we have reached a very good response or a near complete response. This response will be maintained, which is your first remission. And this is the time when we expect the organ function to get better. What is crucial for us is that this duration of first response is reasonably long to allow the organ function to recover. Because if the light chains start to creep up again, the amyloid buildup will start again. And that is where we talk about relapse. Relapse is when the light chains start to come back or the paraprotein starts to come back. So you have remission for a certain period, which is stable disease. After a while, the light chains will start to go up. This is a period which is often pretty worrying for patients because your light chains might drift up a little bit and we have to make a decision. Do you need treatment here? Do you need treatment here? Or do you need treatment here? More often than not, we'll treat patients when they're somewhere here rather than to wait till their light chains have gone back right to their starting value. Refractory is a term that we use when we start a second-line treatment for somebody who has relapsed, and actually the treatment doesn't work that well, and the light chains just remain high. Again, these days, this is very unusual. We don't see it very often. We've got some very good drugs to treat amyloidosis. But when we go through a number of different treatments, we might start reaching a phase where the light chains become harder and harder to control. Hopefully, we get a new drug every 2 years, and we might be able to carry on. But this is what's refractory disease. The main discussion is between yourselves and us at the Amyloid Center and your local treating physicians to decide what is the best treatment for you. We take into account a number of factors. How badly are the organs damaged? What's the kidney function? What's the cardiac function? Is there any evidence of nerve disease to decide which drugs are best suited for a particular patient? And then we also make a decision of what doses of those drugs may need to be chosen. When the light chains come back and there's a relapse, we then have to decide what to do. Do we continue to monitor? We might sometimes do that for a few months before the light chains go high up. If you had a really good response to the first treatment, which had lasted for many years, then one could conceivably give the same treatment again. But on the other hand, if the light chains have got back up only a few months after the first treatment, then we may consider something new. Occasionally, if you're on some treatment and the response isn't very good, we might consider adding a drug to the same 2 drugs you're on. You may be on Velcade, we could add something else to the Velcade to make the response better. When we start treatment for the first time, newly diagnosed patients coming for the first time, the commonest drug we give is Velcade. A lot of you may have received Velcade as your initial treatment for amyloidosis. This is a drug which blocks the breakdown of the light chain protein in the plasma cells. These light chains will then accumulate in the plasma cells and become incredibly toxic to the plasma cells, exactly in the same way they're toxic to the body for an amyloid patient. And the plasma cells will die quite quickly. And one of the drugs which has changed the face of amyloidosis is treatment with Velcade or Velcade-like drugs, and we can see very good and deep responses which sometimes last for a very long time. For some patients, we may still choose to use thalidomide, which is an oral drug. As I said, maybe 10% of the patients are suitable for a transplant. We don't choose that very often in the UK. Other countries, they tend to do more transplants. The jury is still out whether transplantation is better than bortezomib chemotherapy. The feeling is that those patients who get a complete response to transplant, the duration of the plateau phase or the remission after the transplant may be longer than what we see with chemotherapy. And then organ transplant is really not something we would consider as initial treatment, apart from an exceptional patient where the heart may be so badly damaged that we believe that treatment with chemotherapy may not be really suitable or successful. And these are typically younger patients with single organ involvement where we might consider them for a heart transplant. But this would be maybe 1 patient every year or 1 patient every other year. If the disease comes back, this is what we call as the first relapse, then we would like to use something typically that wasn't used the first time around. Our treatment choices here are often dictated by what is funded rather than by what may occasionally be the best treatment. You heard Professor Hawkins talk about NICE, the National Institute of Clinical Excellence, and NICE decides which treatments are cost effective for use in the NHS for first line, second line, third line, so on and so forth. NICE have agreed that Velcade is cost effective for first line. They've also agreed that Velcade is cost effective for second line, but now they have put a restriction on that those who have had first line Velcade can't have Velcade again. So we can't retreat with Velcade even if you had a good response first time. So we would typically use melphalan, which is an oral drug, or thalidomide for second line. And then third line, we use one of these drugs called lenalidomide, which is an improved version of thalidomide. And for third line, we use pomalidomide, which is a further improved version of lenalidomide. That's kind of our general treatment scheme. First line Velcade, second line, one of these 2, and then lenalidomide followed by pomalidomide. Panabinostat is a relatively new drug that has been recently approved by NICE to be used in combination with Velcade. We have very limited experience of using this in amyloidosis. We have been pretty wary of using this drug in amyloidosis because it causes a lot of fatigue, gut symptoms, diarrhea, low blood counts, and the feeling is that patients with amyloidosis already have those symptoms. And making those worse with panabinostat, which only adds a modest benefit over Velcade, probably is not worth doing. There are a couple of other drugs which are not on this list, which we are hoping NICE will fund, which is a newer proteasome inhibitor, a newer version of Velcade-like drug called ixazomib. There's an intravenous version called carfilzomib, and there is an antibody which kills plasma cells called daratumumab. And these are 3 drugs which are currently going through the NICE process, and we don't know where they would slot into. The expectation is that they will slot in somewhere here, but we wait to hear for that. So going back to what do we do at relapse, generally use a different treatment strategy. Occasionally use the same treatment strategy if there was a very, very long response. But we have to be aware that the cells that were left behind after the first line treatment are the cells which are likely to be resistant to the first line treatment. So using a different combination or using a different set of drugs is probably better. Add to the existing treatment is typically in the middle of the first cycle. So if you're on your course of treatment, we think the light chain reduction is not fast enough or not deep enough, we might add something to the treatment to improve the rate of response or the depth of response. Organ transplantation, this is much more about renal transplantation for patients who have achieved a good response, and if the kidneys aren't working too well, suitable patients may be considered for transplantation. And in clinical trials, are something we do quite a lot in amyloidosis now. These are generally new drugs that are in development of testing. And this is kind of the scheme of how a clinical trial goes. Lots of compounds are thought to be very fascinating, might work really well. A whole lot of them are then tested for safety in humans, which is the phase 1 study. A lot of them fall off at this point because we think they're not safe to use. But we can say, okay, this is a drug which is safe to use. We can proceed to phase 2 trials where we can show it actually works. And then phase 3 trials is where we can show not only it works, but it's better than the standard treatment, or at least as good as the standard treatment, to give us a different option. That's when a drug gets licensed. We've got a number of phase 3 trials in amyloidosis. We'll talk about 1 or 2 of those in a minute. And we've got a couple of phase 1 and phase 2 trials in amyloidosis, both with drugs which will kill the plasma cells, as well as with drugs or antibodies which will help to remove the amyloid protein. These trials have to follow very strict rules. We have to take consent. There are very specific patient visits. They are mandated according to the protocol. So it becomes a little bit onerous to follow a trial protocol. We can't choose and decide, okay, this week isn't a good week because I'm having a dinner, so we'll defer the treatment for a week. So we have to do the treatment on day, on time, otherwise we get into trouble. Entry into a clinical trial will be determined by, do you have newly diagnosed disease? Do you have a relapsed refractory disease? And then what exactly are we trying to treat? Are we trying to remove the amyloid, or are we trying to kill the plasma cells? You can choose to go into a trial, or you can withdraw from a clinical trial at any time you wish to do so. What you may not choose is what treatment you have, because the trial will dictate that. The trials often have 2 different arms, a standard treatment and a new treatment. And there's a randomization, which means you're randomly assigned to one of the 2 treatments, and we don't have a choice who gets one or the other treatment. We can't decide when you start the treatment or whether you have any extra tests. The trial protocol mandates what tests have to be done, and we have to continue with that. The trial has got fixed criteria who can go into the trial. We can't modify those. So if you don't fit the criteria, you can't go into the trial. We often have patients whose kidney function isn't good enough to go into a trial, whose heart function isn't enough to go into a trial, so we can't get them onto a trial, even though we think the trial might be a good option for them. You can go into a trial if the trial treatment fits what you need, not just because there's a trial there. And if we think that is one of the best options for you, there's always a non-trial treatment option that we can give you if the trial isn't the best thing for you. And the key thing is if you're prepared to come as frequently as the trial protocol dictates, at whichever time the trial protocol dictates. Generally, these are reasonable protocols, and the visits involved maybe a little bit more than clinical visits. We often see amyloidosis patients very frequently in clinic when you're having treatment, so the trial protocol may not mean too many additional trips. These are some of the trials that are ongoing at the moment. This is the antibody that Professor Hawkins will talk about later that was developed by him and Sir Mark Pepys in our unit, which is the antibody to remove amyloid by binding SAP. This is the Prothena Neo-001 antibody. This was in 2 phase 3 clinical trials. One trial was for patients with newly diagnosed amyloidosis in the heart, and the second trial was for patients who have already completed treatment but continue to have cardiac dysfunction. Both these trials have now recruited fully. We have got patients who are receiving this treatment on the trial. This is a double-blind trial, so we don't actually know which patients are getting the drug, which patients are getting a placebo. Carfilzomib is a new proteasome inhibitor, an improved version of bortezomib. We've got a trial which has just opened, combining this with thalidomide for patients whose disease has relapsed after initial treatment. And most patients with relapsed disease would be potentially eligible for this trial. And then ixazomib is an oral version Velcade-like drug. And this is another trial which is still open to recruitment. These are patients who have had a first-line treatment and then have relapsed and have never had Velcade before. Unfortunately, because of the criteria of not having had Velcade before, there are only a small number of patients in the UK who are eligible for this particular trial. But hopefully, we'll see the criteria expand and allow us to recruit more patients in the future. So I hope we have gone through how do we measure response, what do we measure, how do we detect disease relapse, and briefly covered some of the treatment options that are there for AL when the disease is active initially and then it becomes active after initial treatment. And the take-home messages are the same. We can't cure it, it can come back. We have to keep on doing tests and monitor your symptoms, and there are very good treatment options available if the disease does come back. And these are some things which Myeloma UK provide, the info guides and info sheets. You have videos of the previous meetings and of a variety of us talking about treatment of amyloidosis. And then you've got this very nice 3D animations telling you what amyloidosis is. Thank you.